Thank you for the invitation, Carlo and all the group, Poseidon group. And it's a relatively not so difficult, speaking on similar audience, because usually antral follicle count is so important for all of us. And this obviously derived from artificial intelligent imaging. This is the world of fantasy with a very young woman, and this probably the reality is completely different. In this scenario, it's very important to looking for a Pied Piper that can help to enter in this strange world. And probably the antral follicle count can be a useful tool for that. In my presentation, I will speak on different things, mainly based on technical suggestion to increase your capacity to evaluate the antral follicle count, but also understand the meaning of some tools to improve these results. Also the importance of this very thin measuration kind of particular measurement. And also, I suggest always, as gynecologists, to use this moment, the antral follicle count, to improve our knowledge about the physiology or the cause of fertility or infertility in our patients. This very simple definition is the follicles. You can count all the follicles ranging from 2 to 10 millimeters. It's very easy, usually, perform this kind of evaluation, and it's completely related with the decrease, typical decrease of fertility, increasing the age of the woman. And this study started some years ago, correlating the anti-Mullerian and antral follicle count. For us, it's relatively easy to send a prescription with anti-Mullerian, but I think it's having in our hand a lot of information possible using antral follicle count improve a lot of our knowledge of the problem of the ladies. And this is clear evidence of this correlation. There is also a correlation with the poor ovarian response between antral follicle count and also anti-Mullerian. And the study this morning, other presenters showed these slides. There is a clear evidence. There is a correlation with these different markers, markers of the ovarian reserve, and with some difficult in some case to use algorithm, but the problem is probably is a clear evidence that both markers work more or less in the same manner, but probably is not just my opinion. Antral follicle count has some additional things. And a recent review showed that I work also in other kind of pathology, cancer, endometriosis. This is a relatively good receiving operating curve, but not so good as expected, probably. But it's not so bad in comparison with other tools. For example, FSH and estradiol is not so good, probably a lower accuracy to define a poor response or a high response. And there's a meta-analysis recently published showing that these markers are really good, both are really good to predict a poor response and also a high response. Altogether, this marker shows an interesting area under the curve. But Cochrane review say, oh, there is no clear evidence to support or reject the use of ovarian reserve test to select the stimulation. Either in relationship with the live birth, also for the ovarian hyperstimulation. This is sad news, but probably everything is more complex than suggested in this review. I fight during my career with some assumption derived from Cochrane review, but obviously the methodology is very strict, but the interpretation in some cases not so good as expected. But it's probably in this field, the possibility to include in our evaluation more things and use some additional things inside the models, using, obviously, big data, for example, for artificial intelligence, I think this is the new possibility in a near field. I always speak about intelligence, artificial intelligence, in several parts of this presentation, because I think it's with a good application, it's probably a new frontier. And as the colleagues showed before, is a fundamental part of the classification of a low prognosis group based on the Poseidon group. But why we have to measure accurately these follicles? And also probably there are some tools to improve our capacity to recognize better the follicles. And this is a long story. It's not the follicle. The smaller follicle are more important than bigger follicle, also in the range of 2 to 10. Smaller follicles are more important, and there is a clear evidence that this follicle we have to try to measure, because size matter. In this case, small size are more important than bigger size. And this study from Unco group showed the importance of very small range from 2 to 5 in the prediction of our capacity to obtain a good response from the ovary. And this is a Carlos study with others, and identified that in this group with very small follicles, you can predict your capacity to obtain more than, in this case, in this particular study, 9 oocytes. But the story on transfollicular count is a very long story, and more than 20 years ago, we started to evaluate this process to obtain this information, and but this is a practical guide to show to the operator how perform a good evaluation of antral follicles. And in this moment in the market, there are mainly 2 methods: traditional manual method using just a simple 2D probe, and automated method using 3D probe. It's fundamental as operator and to standardize our approach to use a particular phase of the cycle, but there's no clear evidence this particular phase of the cycle improve your capacity to predict future response of these ovaries. And probably there is no clear evidence to standardize always in the first part of the cycle, this evaluation. More or less, the differences are not so good. Also, this also emphasized in this paper that they suggest that this evaluation can be performed in any part of the menstrual cycle. As I'll show you at the end of my presentation, it's probably the first part is better to some information with the actual machine present in the market, the capacity to recognize some things that are important. If you want to perform, for example, a evaluation of tubal patency, this phase of the cycle is probably better. But this is just a suggestion, practical suggestion. This probably you can perform this evaluation in all the cycles. And regarding the effect of the oral contraceptives, for example, my patient take before the evaluation, because the majority of patients in my practice is endometriotic patient with endometriosis. Usually I use this evaluation during oral contraceptive to avoid pain and dysmenorrhea. But probably you can use this part. There are some problems with the very reduced count, but in the majority, with normal or with patient with the high number oocyte, the effect of oral contraceptives is not so great. There is no influence in the clinical practice. Some very simple things to remember, performed from people with some education. There is a learning curve, obviously, using always transvaginal approach. The probe is to be 7 megahertz, and use the careful scan the ovaries in on the scan, starting from the left to the right, spend time. It's very relatively easy, and short time is few, is for each ovary very few seconds in the majority of cases. But you have to have a learning curve, as for everything in medicine. It's not so long curve, just probably 20 evaluations are absolutely sufficient. But the market sends us different things, real time, cine loop, manual mode, so on, we'll see. I will spend just a few information about each method. And probably the real time is the best time. For me, it's very relatively easy. Not because of my daily practice, but it's relatively easy. It's also easy to teach, to explain. It's not so demanding, also for residents, young residents. And you're performing the same manner everything. It's not a creative moment, usually ultrasound. It's a moment to be standardized approach. We demonstrate this in the several years of work. But I suggest to use some tools. For example, the second harmonic is important. It's probably also important in some cases of the use volume contrast imaging. It's some tools. And multiplanary, for some people, is just a little confounding. But absolutely, the harmonic image is fundamental because it reduces the artifact. The black is really black and the white is really white, and it's probably you can move the probe very gently, because the frame rate is reduced, and probably you can move the probe in the right manner to avoid this particular to pixel more or less the image. This is a moment to visualize better. You can improve the pressure and obtain better images. And also is useful for in case of very few follicles. Unfortunately, some years ago, there is some studies interesting using CineLoop. Is a very short video for each ovary. It is probably good for research, but not in the daily practice. It's time demanding. It's not so clear to the information when we obtain with this using this very short video. And 3D is probably is the revolution. We use a lot in my daily practice in other fields, but the step is always very simple. Step by step, you obtain this information, and we obtain a volume of each ovary. It's obviously incredibly interesting from the research point of view, because to maintain our library of volumes, it's very interesting for that. But when for example, we use some particular tool as inversion. Inversion mode is interesting in case of this kind of beautiful images, but probably is not so helpful in terms of clinical evidence. The VUSI is interesting. Volume contrast is interesting because it increases your capacity to recognize. After you have this information, can also your acquisition is usually faster. The revolution some years ago was proposed by several companies, the automatic volume count, two major companies, more or less. And it's interesting things, because the problem, all the people say, oh, okay, anti-Mullerian is a reproducible approach, antral follicle count is not so easy to reproduce, but it's probably the automatic count can improve theoretically. Unfortunately, the automatic evaluation is frequently imperfect. You can modify, add, change, and it's not, and it also remain time demanding. And this is not good as expected. And also from the relevance, after some studies, they create, obviously, it's quicker for some authors and with a lower variability. But in terms of, as this Nick Rennefelling showed, there is no effect in terms of clinical pregnancy, between real-time and 3D automated sonography. Okay, there are some limits in our approach. The learning curve is not so difficult, but probably you can use these new tools. It's recently released. Is AutoCaliper tool. You just click with using this small and and you can check, in a few seconds the capacity of your machine. It's easier in comparison with the other approach, totally automatic approach. Interesting, some theoretically, but not in the daily practice. Again, tools derived from artificial intelligence. I suggest always this, we published this review, this practical guide some years ago with some colleagues from around the world, to standardize a report, to describe in a more in a clearer manner if you perform this evaluation during oral contraceptives, the number of follicles, and also the technique that they use. I also suggest to insert some information about the presence of dominant follicle, cyst, and tumor. And this is the last part of my presentation, is regarding this fundamental step. We are in front of the patient, we perform this evaluation. They're very fast, we go a few seconds, measure the dimension of the ovary, counting the follicles. But there is a moment, and it is from pioneers, Stuart Campbell and other colleagues, about the importance to have this moment to obtain all this list. During this 20 years, some of this information, these tools are not useful now because probably nobody takes information about peak systolic velocity and so on. But all this information are very important also now. But 10 years after, from USA, Beryl Benacerraf, and this now is very used in our daily practice, a so-called one-stop shop. In one evaluation, in few minutes, because it's using also, performing also ICOSI or IFOSI, depend. For the evaluation to patency, you add this information in 20 minutes of examination. It's very, very impressive information in our also. And the great advantage of this moment with the patient is to obtain the list of all this information. Also, this is my daily practice, also information not only for the malformation and fallopian tube hydrosalpinx, for example, but also for the presence of endometriosis. I suggest to use this structured approach to follow different 4-step, just 4-step, to have the information. It's very useful. This is not a normal patient. This is a patient with incredible endometriosis, and you can improve your information in the daily practice with very few minutes. It's not 30 minutes, just in the majority of cases, this evaluation can be performed in 5 minutes in case of normal things, but in case of complex case like this, obviously, is longer. And I move to the next slide, but just to show the presence of this ovary. This is not a normal ovary, okay? It's not the right position. It is stuck to the uterus for the presence of adhesion. And this is the dramatic effect. And just a few words about the concept of ovarian reserve screening. I have some fear to introduce this in the clinical practice to young women, for example. And I support completely this committee opinion from American Society of Reproductive Medicine. Because for me, create an ovarian reserve to predict current reproductive potential among women with unproven fertility is very, I think it creates fear in every woman when you start to speak about that. It's different, obviously, for patients for endometriosis and different, but it's a normal patient. I think it's not so good to start to speak about that with these ladies. And just a few words, this is my last slide. And during all the cycle, usually I suggest to perform 2D. Size are important. Check to take this information from 2 to 5 follicles. Use at least the second harmonic. Is very decrease just a little your capacity to move faster the probe, but this is important tools. And also, please use this moment to improve your knowledge about this, your patient, about the potential cause of infertility. Thank you very much for your attention.